Good evening, everybody. I am Pethuru Devadason. I am basically from India. I was working as a teacher in a medical college till recently, and now I have moved to Kuwait, working as GP. The topic of my presentation today is passive smoking and its effects among children of a rural population in South Tamilnadu, India. We all know that tobacco kills many. Nearly 6 million people each year are killed by tobacco. We all know that 70% of tobacco is of smoking form, and of these 6 million people, more than 5 million people are killed by the direct effect of tobacco, but just less than a million, they are by an indirect effect, that is by passive smoking. Passive smoking refers to the breathing tobacco smoke that is breathed out smoker or comes from the burning cigarette. This is otherwise called second-hand smoke or inactive smoke, like that. We all know that smoking is injurious to health. Of course, the same passive smoking also. But when we talk about smoking, we consider the health of, but children are exposed to the ill effect of smoking as their immune system is not yet developed to tackle the irritants. It is roughly estimated that 40% of the children exposed to their passive smoke around the world. First one is the negative outcomes like sudden infant death syndrome, croup, bronchitis, pneumonia, ear infection, asthma, learning difficulties, behavioral problems, and heart diseases are more in children chronically exposed to passive smoke. And also, these children are 4 times more prone to become smokers in the later age because of the conditioning effect in the body. There are n number of studies in the world on the effects of smoking, especially in the rural population, but the same on children is studied in very less amount. And also passive smoking among children is not widely studied. So in this context, this is being done in our study area with the following objectives: to determine the prevalence of passive smoking among children in a rural population in South India. Second objective is to find out the effects of passive smoking on children in the study population. This is basically community-based cross-sectional study. It was carried out in a Marapadi village in Pulasheram Panchayat of Kanyakumari district in Tamil Nadu. It is the southernmost. This study was conducted in October 2014. 150 children under 15 years were approached in their houses in the village with a questionnaire to collect their socio-demographical details and the history of passive smoking. Those under the age of 1 were excluded from the study, and also the history of low birth weight, growth retardation, number of upper respiratory tract infections, lower respiratory tract infections, ear infections, allergy, asthma episodes were elicited. Data collected were entered in Excel sheets and analysis was done using SPSS version 16. And the following is the results. There were 150 children under 15 in the study, which were collected from the 96 households. They were, according to the table, 82 were male and 68, that is 45% were female. 1 to 5 years were 20%, 6 to 10 years were 47%, and 11 to 15 years were 33%. And this is the result of the household environment among the people, those who have passive smoking and also not having passive smoking. According to this table, overcrowding, adequate ventilation, smoke from the kitchen, anti-mosquito smoke that is commonly used in the villages for the mosquito problem. These environmental household factors are obviously more in the passive smoking area than the not passive smoking area, as the first two factors are statistically significant, that's 1%. So that much these factors are significant. And when we look at the morbidity conditions of passive smoking, morbidity conditions of the children, the passive smoking, the height and weight are not significantly different among the passive smoking and non-passive smoking. But the number of upper respiratory infection in a year, the mean number was 7.1 plus or minus. Household environment associated with the people having smoking than people not exposed to smoking. So this shows that this is adding fuel to the fire of the already existing household environmental risk factors. So the parents and the stakeholders of the community to take note of this point to tackle this passive smoking issue. And in the last slide, these morbidity conditions were not significantly associated with significant difference between the both group. That is obviously maybe because of the lesser sample size, because the study population showing only 21.3%. So I should have taken double of the sample size. Then I should have run the analysis. So conclusion of the study is prevalence of passive smoking in my study is 21.3%. It is much lesser compared to the global scenario. Environmental risk factors like overcrowding, lack of adequate ventilation, smoke from the kitchen, and anti-mosquito smoke are significantly more associated with children having passive smoking. Upper respiratory infections are more significantly associated with those who have the history of passive smoking. So the significance or the recommendation from the study is morbidity conditions are more with those who have the history of passive smoking. So particularly their parents also to be motivated to stop smoking, especially inside the house while the children are around. And children with the history of passive smoking is also having the other environmental risk factors like overcrowding,